Good afternoon, students. First of all, must apologize for the late start. It's been raining, I would say cats and dogs in Jamaica here. And you know, everything slows down in Jamaica when it rains. So we're off to a bit of a late start. But remember, I have 4 hours of lab with you on the hand. 2 hours today and 2 hours next Tuesday. What I plan to do today is to discuss the bones and joints of the wrist and hand, and then I'll get into the soft tissues of the hand, which is really the intrinsic muscles. I did the forearm and wrist with you, where we met the extrinsic muscles, the flexors and the extensors. So I'll be showing you those also in the hand. I'll be showing you the tendons in the hand. What I'm going to do first of all is just do a quick review of the bones, because I know that most of you don't have access to the bones. So I want to start with the humerus right here. Right, so here is the humerus, and we can see the medial epicondyle here and the lateral epicondyle of the humerus here. We can see the rounded capitulum of the humerus and the trochlea, right, with its groove in the middle, right? So the trochlea and the humerus. The trochlea is going to articulate with the ulna and the capitulum with the head of the radius, right? So we come down to the forearm bones now, and I'm going to take you through the radius and the ulna. Remember when we discussed the forearm and the hand, that posterior is dorsal, right? Anterior, right? When it comes to the hand, we call it palmar. Anterior is also flexor in the forearm, right? So the flexor compartment is anterior. When you get up into clinical medicine, you realize there's another term for palmar, and that's volar, V-O-L-A-R. But we won't be asking you, we'll be referring to the side closest to the palm as palmar, and the dorsum as the posterior part. So I'm looking at the anterior view of the radius and ulna here now. And here we have the head of the radius, right, that has really one continuous articular facet, but it's for two joints, basically. Two joints of a compound joint, which we call the elbow joint. So the capitulum here is going to articulate with the superior surface, right, of the head of the radius, and the sides of the articular surface of the head of the radius is going to articulate with this notch that we see here on the ulna, and that's called the radial notch on the ulna. All right. So we leave the head of the radius and we come down. That's the neck of the radius, and here is the radial tuberosity. And I'm certain someone can tell me there, right, what muscle is inserted in the radial tuberosity. Anyone? One person? Okay. All right. A little later I'll ask some questions. All right. I'll bring up Michael Lamond. You were in my lecture this morning. I remember that. All right. Michael Lamond. Okay. So what muscle? Okay. The biceps brachii. Very good. Excellent. All right. Okay. All right. So Mr. Gardner would say 300%. All right. And we come down from the radial tuberosity, and we see the anterior oblique line. The anterior oblique line. And we know that one of the attachments of that great muscle, the flexor digitorum superficialis, that is right here. Right, okay? Right? We come down the radius, this is the interosseous border, and if we look, I'll bring a single bone so we can look. Right? We can see that in the forearm, head of the radius is proximal, and the base is distal. Right? Whereby for the ulna, the head is distal and the base is proximal. Right? So as we get down on the base of the radius, this is the radial styloid, and we can see that on the articular surface of the base of the radius, we can see two facets. This facet is for the scaphoid, right? Okay, and this facet is for the lunate bone. That's going to be part of our joint we call the wrist joint or radiocarpal joint, which I'm going to show you. All right, radiocarpal joint. The lower end of the radius also has ulnar notch, right? Okay, medially here. When we speak about the forearm, right? So this is a left forearm here. So the radius is lateral, right? And the ulna is medial. So if we talk about the hand being adducted, right? Like this. Remember that everything is described in the anatomical position. If the hand is adducted, right, it means it's ulnar deviated. And if it's abducted, it's radially deviated. Right, okay? Right? Because we always remember the radial border and the ulnar border. Ulnar border is medial, so this is the left forearm. Alright? We come to the ulna now. Alright? And we'll get this ulna and show it to you because it's better than. So we'll have to work out first of all which side this single bone is on. So we put them together like this, and we realize that this one is left, right, and this one is right, right? Okay, because laterally here is the anterior part of the radius, right here, right? Okay, right, and this is the lateral or radial border of the forearm right here. If we look at the ulna, we'll see the olecranon process up here, right? Okay, and this other process anteriorly is called the coronoid process. Coronoid process, right? And if we look, we'll see a trochlear notch, and this trochlear notch fits into the trochlea of the humerus. All right? Okay. All right. Now, on the medial side of the coronoid process, right here, this is the radial notch, right, on the ulna. That's for the superior radial ulnar joint, right? And here we see another tuberosity, right? And this tuberosity is the ulnar tuberosity, and that's where the brachialis muscle is inserted, right? This is a very important part right here, which students don't really get to know very well because they may not have the bones. But this is called the sublime tubercle. The sublime tubercle, because I'll show you the sublime tubercle because this is the medial epicondyle here, and the flexor digitorum superficialis has a humeral ulnar head which is attached, right? Okay, sorry, from the medial epicondyle to the sublime tubercle. Then it continues down on the anterior oblique line of the radius, and in between there's an arch, a fibrous arch. Right, okay? So the flexor digitorum superficialis have three origins really: humeral ulna, anterior oblique line, and the supinator arch. Right? There isn't much more to show you on the ulna, right? Except the ulnar styloid. This is the ulnar styloid here, right? Ulnar styloid is right here, right? Okay. Now there is a it's more like this, right? So there's the interosseous border here, and the interosseous border of the radius, interosseous border of the ulna. Right? That's a nutrient forming. And then you see that in the bone, right? Right here. You know that's the blood vessel that has gone into it right there, right at that point. Right? The nutrient forming. Now, we're going to talk about the wrist joint first of all. And the wrist joint, right? The wrist joint, the ulna plays no role in the wrist joint. There is a triangular fiber cartilage. Yeah, that's better, yeah. Triangular fiber cartilage that runs from the ulna styloid to the base here, right, okay, of the ulnar notch on the radius. And that triangular fiber cartilage separates the inferior radioulnar joint from the wrist joint. So the proximal articulating surface of the wrist joint is going to be the facet for the scaphoid, the facet for the lunate, and the articular and the triangular fiber cartilage. And some of you may have remembered that I showed you this morning, right? Okay, on this here, right? Okay, that's a picture of the distal end of the radius. So this is the articular surface for the scaphoid, the articular surface for the lunate, and this, what you're seeing here, that's the triangular fiber cartilage. You wouldn't see that in dried bones because fiber cartilage would disintegrate afterwards, okay? All right? We're going to move on now to the carpal bones, all right, okay? The carpal bones right here. That's good, all right, okay? That's good, yeah. So we're on the radial side. Always start by the thumb. Trapezius is the bone by the thumb. We'll start the proximal row first. Right, okay, so the proximal row is the scaphoid. And you can see that scaphoid. Right, it's shaped. Okay, it's a better one. Well, that's the good one, huh? You get confused. So the scaphoid is shaped like a boat. Right, okay, and has a tubercle in it. Right, then this is the lunate. And this bone here, under here, this one under here, right, okay, that is the, that's the triquetrum, that has three sides. On top sitting on the triquetrum is the pisiform. Pisiform means P. Right, we go back to the thumb again, and that is the trapezium. Then we have the trapezoid, that little bone is stuck inside there. Right, you can see it right in there. Right, it's in there. Right, trapezoid. Right, okay. And then we have the massive capitate and the hamate with the hook. The hamate with the hook. So when the bones line up like that, what's going to happen is that there's a tubercle here on the trapezium and a tubercle on the scaphoid, and they are going to project palmar of the other bones, right? Okay. And on the other side, that is on the medial aspect, because this is the left forearm. We can see the hook of the hamate and the pisiform, and a big ligament runs across here called flexor retinaculum. The flexor retinaculum. So the ulnar attachment of the flexor retinaculum, the ulnar side attachment, okay, is the hook of the hamate and the pisiform, and on the radial side, it's the tubercle. I just call them tubercle. Some people call this a ridge, but tubercle on the trapezium, and the tubercle on the scaphoid. All right. So I wanted to show you, right, the wrist joint. All right. So the wrist joint is really called the radiocarpal joint because it's between, right, that's good, between the radius here, right, and the scaphoid and the lunate, right. The triquetrum, right, this is it. Remember the proximal articular surface. The proximal articular surface, I just showed you here. That's the proximal articular surface of the wrist joint. Right, okay? Right? It has a concave surface, whereby the distal articular surface of the wrist joint, this is the wrist joint. These are not the wrist joint. This is the wrist joint, or radiocarpal joint. Right? The proximal one. This is convex. This whole, the scaphoid and lunate, you can see the shape. They're convex. They have a male convex shape, right, like that, fitting into a female concave shape. And then what you can have flexion, extension, ulnar deviation, which is adduction, and radial deviation, which is abduction. And you can also, at the wrist joint, you can also rotate or circumduct the wrist joint, right? All because it's a condylar joint. The wrist joint or radiocarpal joint is a condylar joint. There's another joint in the wrist, it's called the midcarpal joint. The midcarpal joint. And that midcarpal joint is between the proximal row and the distal row. And it's sort of S shape. You can see an S there between the proximal row and distal row. That contributes a little to movement of the wrist, but that's not the wrist joint. That's a midcarpal joint. So you do get a little flexion in it, nothing much more, a little extension, but not much more. Almost all the movement you get at the wrist joint is at the radiocarpal or wrist joint. When we talk about the wrist joint, that's the radiocarpal joint. You can hear the thunder out there, guys. We're having quite a bit of weather here in Jamaica today. All right. Then, next thing we're going to talk about now, all right, so we'll leave that alone, all right, okay, and then we're going to go to these very important joints here, the carpo-metacarpal joints. I showed you them in the lecture this morning, the carpo-metacarpal joint. The carpo-metacarpal joint. All right, so we have the radiocarpal joint, wrist joint, the midcarpal joint, and these radiocarpal and midcarpal joints, they're all held together by two big ligaments on either side. On this side, I can show you the picture here. There's a picture of it here, right? Okay. So that's the proximal row, that's the scaphoid, and that's the lunate, and that's the articular surface here for the base of the radius. And you can see the massive ligaments on either side there. This is the ulnar collateral, and that's the radial collateral ligament. There are a couple of others, dorsally and ventrally, but I wouldn't want to call the radiocarpal, dorsal radiocarpal and ventral radiocarpal, but don't worry too much about those. As we come into these other row of joints here now, right? And these are the carpo-metacarpal joints, right? And four of them here, that's the ones, right? Okay, these four here. Always remember, this is the left side we're dealing with here. So this is the number one metacarpal bone. The metacarpal to thumb. 2, 3, 4, and 5. They are the metacarpal bones, the index, middle finger, ring finger, and little finger. Now, 2 to 5, they are planar joints. Planar joints, and there's very little movement of them. Almost no movement of two of them. A little bit at the third one here, and a little bit more at the fifth carpo-metacarpal joint. But those have got to be firm, because that's how you're able to lift up something with your hand. Your hand has to be mobile, but at the same time solid enough to lift up something. So these joints are planar joints, right? Okay, or gliding joints. But in this case, let's call them planar joints. There's no, right? And it also in between. By the way, in the metacarpals, the heads are distally and the bases are proximally. The heads are distal, the bases are proximal. In between the bases of the metacarpal here, we have the intermetacarpal joints. Now we're talking about 2 to 5, not the thumb. Thumb is a special case. Right? The carpo-metacarpal joint of the thumb is different. Different ball game completely. Right? These are fixed. No movement. If I show you my hand here, right? All that, I don't think I can get off the block now for now. Right, okay? right? All that the fifth joint will do is help you to make a little cupping of the palm like that, right? Okay? But the rest there are almost no movement to them. Whereby the thumb now, look what it does. It can adduct, it can abduct, it can extend, it can flex. It can also rotate like that and can oppose, right? So the thumb is, you can see it's set apart from the others. It's like a free agent. It doesn't need a contract, right? They're waiting to have a contract. It's on its own. It's not a, right? It's completely different from the others, right? So the thumb, the carpal metacarpal joint of the thumb is different from the other carpal metacarpal joints, right? So if we look at the reason why, we look at the surfaces. And if we look at the surfaces here, we'll see that it's saddle shaped, right? In one plane, here, this part is convex, and the other part is concave. And the other plane, anterior posteriorly, this is convex, and this side is concave. So it's a biaxial joint, right? It has a lot of different movements, right? Okay? Right? Flexion, extension, adduction, abduction, right? Okay? Opposition, right? Okay? And you can also rotate yourself into the direct position, right? Okay? Right? So that is probably the best example of a saddle or sellar joint, the carpal metacarpal joint of the thumb, right? By the way, if you have any questions while I'm talking, you can just say something to us and I'll step in. But I like to wait like halfway, 10 minutes for questions, and then at the end again. All right, okay? All right. Now, we leave the carpal metacarpal joint of the thumb, and we're going to come now to the MCP joints, metacarpal phalangeal joints. MCP, metacarpal phalangeal joint. These bones here in the fingers, these are each one is a phalanx, and they're the phalanges. Right? So this is the proximal phalanx, the middle phalanx, the distal phalanx. But the thumb only has two phalanges, proximal and distal. Those joints up there are IP joints, interphalangeal joints. We'll come to those. But we're going to talk about the metacarpal phalangeal joints from fingers 2, that is our index finger, middle finger, ring finger, and little finger. Those are different from all the others. Those again are condylar joints. Look again. That's a rounded, convex, that's the head of the metacarpal, 2 to 5. Rounded, convex surface, which fits into a female, you can see here, concave surface on the base of the proximal phalanx. Right, let me show that to you on the light. Right there. You can see that here, right there. Right, that's a female concave surface, and this is a male convex surface. So this joint can flex, extend, abduct, which is radial deviation, abduction, radial deviation, and adduction, right, okay, which is ulnar deviation, right, okay, and it can also, look at that joint, it can also waggle, right, okay, you can also waggle it, so you can circumduct it. That's the carpal metacarpal joint from 2 to 5. So those are condylar joints. These others are hinge joints. All the IP joints are hinge joints. Right? All of the IP joints, interphalangeal joints are hinge joints. Also, the metacarpal phalangeal joint of the thumb is a hinge joint also. Right? They're only capable of flexion and extension. You can see that there's you look here, right? You can see a groove and a ridge. A groove and a ridge. Right? So they can only move like that. Flexion and extension. Right? And they have a lateral ligament that's specially designed to be taut in flexion, taut or tense in flexion as well as in extension. Alright? Those are the things I wanted to say about the bones. All right, okay? I'm going to just show you a few landmarks, all right, okay, on the hand. All right, okay, so I'm going to deal with I think I have on my watch here, so I'm going to start with my right hand here. And I think everybody would recognize that tendon. All right, anybody can tell me what tendon that is? Who tell me that? Shamia Pintad. Head of the metacarpals are distal. All right, again, the bases are proximal. All right, Michaela. All right, who's going to Karim? Karim is Ismail. Ismail, what tendon is this on the forearm? Prominent tendon. As the flexor carpi radialis. Flexor carpi radialis. Right, you can't miss it. Right, okay? Once you make a fist like that, everybody has it. Now, next to me, next to that, medially, remember this is the forearm here. I remember Dr. Shetty has done the forearm with you, so I'm not going to go over the forearm, but I'm going to be talking about some of those muscles that are coming into the hand. Right, okay? So, if you put the heel of your left hand on your proximal, on your medial epicondyle like this, then you can find the 5 muscles. You put your index finger on the flexor carpi radialis, right? The tendon that is most ulnar is the flexor carpi ulnaris, flexor carpi radialis. The tendon is going to go across the hand like that with a big finger, that's the pronator teres. And then next to the flexor carpi radialis is a little tendon right here. In me, I can only feel it, but in some of you it's more prominent. That's called that tendon right next to it here, right here. Right, you feel right next to it here. That's the palmaris longus. And then these tendons you see popping up here, those are the flexor digitorum superficialis. So I'm going to show them to you, right, okay, and the distal forearm, right, okay, right, okay. The other thing I want to show you is here, we have two skin creases on the flexor aspect of our wrist. The prominent distal one, like this here. Prominent distal one. Right? Prominent distal one, that's usually when I'm releasing a carpal tunnel, right? Okay, dividing the flexor retinaculum, that's where I make my incision, right here. I haven't done that operation for a long time. That is the days when I did orthopedics. That's a long time ago. Right? Okay. So that's where the flexor retinaculum starts deeper, right here. Right. Now, if you feel right at the medial aspect, well, let me just go back here again. Right. If you go right, just radial to the flexor carpi radialis. And you put your finger right there like that, right, okay, like this, you feel the radial pulse. At that point, the radial artery is subcutaneous, right? So you can feel the radial pulse right there. If you come back along this distal palmar wrist crease here, and you feel right at that point, you feel your pisiform right here. That's your pisiform right there. And if you just go medial to the pisiform and just sink your finger in there, you feel the ulnar pulse. You feel the ulnar pulse. So if you're not able to do that right now, just try it a little later, right, when you go in the quiet of your room. But right now I'm feeling my ulnar pulse there. And I have one Fitbit that tells me that I'm doing what? 69? My pulse is 69, so that's good. Right, okay? Right, okay? So that's my ulnar pulse. Alright? So now, I think we can start. Oh yes, looking at the palm of my hand, right here, this is we see some creases. These are just called the transverse palmar creases, okay? So this is the distal transverse crease, and this is the proximal transverse crease. This one is called the oblique crease, or thenar crease, right? because this is the thenar eminence. So a distal transverse, a proximal transverse, and an oblique crease. It varies a little from person to person. Yeah? And this hand it varies a little. Alright, okay? Alright? So the distal, proximal, and this is the oblique right here. Alright? The thenar eminence, you can see here, is this master muscle right at the base of the thumb, and this is the hypothenar eminence. So when we come to talk about the palmar aponeurosis, we're going to be talking about this part here, right in here. What I'm going to do first is start showing you some things now, right? Okay? I know that's what you came to the lab to do. So I'm going to show you the muscles in the forearm, right? And I'm going to show you how they go through the carpal tunnel. And I'm going to show you the flexor retinaculum. And I'm going to show you the extensor retinaculum. Alright? So let's get down to it and start looking. Alright, okay? I wouldn't be able to show you the pronator teres, I'm too far distally here. Alright? So if we look, that tendon I just showed you there a while ago, that prominent tendon, this is it here. Alright, you can't miss this on the forearm at all. But by the way, I'll leave that one alone for the time being. Right, this is the prominent tendon that I showed you, and that is the flexor. Alright, so this is here. This is the flexor carpi radialis. Right, okay? And remember, I showed you that if you felt just a little lateral to it, right, you'll feel the radial pulse. Right, okay? Right? So right on the radial side of the flexor carpi radialis as a radial pulse. And we're going to trace the radial pulse through the anatomical snuff box all the way around into the hand. But remember, we have two labs, so we won't get through everything today. Right? So this is the flexor carpi. Anybody can remind me where the flexor carpi radialis came from? Where does it arise? Nadia. Flexor carpi radialis. Huh? From the medial epicondyle. Very good. That's called the common flexor origin. I don't want you to think they all come from that one point there. There's a kind of aponeurosis there, right? And that's where all the muscles, 5 muscles have an origin there. All right. So if we look at the tendon that is medial or ulnar of the flexor carpi radialis, that's the palmaris longus. And anybody can tell me what is this part we're seeing down here? That's cut away already. Anybody can tell me what that is? It's going into a triangular fibrous formation there. Part of it. Brianna, the palmar aponeurosis. Okay, so we're going to move that for the time being. Right, okay? Now, we come on the ulnar aspect of the forearm now. So if we did that, right, okay, flexoris and ulna deviate a little, you can feel that tendon there, right, okay, and that's the flexor carpi ulnaris, right, flexor carpi ulnaris, right, okay. And then if we look here now, here we have these two. This is the ulnar artery, and this is the ulnar nerve, right, ulnar artery and the ulnar nerve. You can see the difference between the nerve and the artery, right here, okay. Always remember that the ulnar nerve is peripheral to the ulnar artery. And the radial nerve, which we're seeing here, that radial nerve we're talking about, the superficial radial nerve, I'm going to show it to you in a little while, right, okay, is peripheral to the radial artery. Right? Median nerve, that's this big boy right here. You see it? See how big the median nerve is? Right? Right? That's the median nerve. And what I've done here for you is to cut this strong thing right here, which everybody can see. I want everybody to see this. Right, okay? Right? This is the flexor retinaculum. You see how thick it is? Can I just show you? No? Alright, there we go. Okay. That's good. Very good. That's the flexor retinaculum. Alright, okay? So I'm in the carpal tunnel there. Alright, okay? Now, let's see if we can find the other tendons. Alright, okay? So we pull these things aside, put this aside, and right between palmaris longus And flexor carpi ulnaris, what do you think these tendons are that we see in here? This is, oh no, this is the radial nerve, so put that away. Alright? Anybody can tell me what those are? What muscle is that? Between the palmaris longus and the flexor carpi ulnaris. A little bit deeper. Flexor digitorum superficialis. 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 If we go distally now, if we go deeper now, right here, right, you see 4 more tendons right here, right, coming from a big muscle, the great gripping muscle. What is that one? Flexor digitorum profundus. If we go a little medial to that here, right, we have this one that has a unipennate appearance. You can see the unipennate appearance there, right? A little like that. A little. All right, so here it is. The muscle fibers are coming in from one side of the tendon, like a half of a feather. So the unipennate muscle, right? Okay, there's the flexor pollicis longus. That's going to go to the big finger. All right, we come around now, and what we come to here is the anatomical snuff box. All right, we come to the anatomical snuff box. All right, so everybody can find the anatomical snuff box. All right, everybody can find that place. Profunda, which one? The flexor digitorum profundus. Right, that is deeper. Right, once you go deep to these muscles, right, these tendons here, right, you're not going to see it too well. You understand? Right, because that's a deep muscle that you see there, the tendon. They are right down. Right, remember there are 3 deep muscles. Right, okay, 3 deep muscles. So you have 5 superficial, and that's it. Flexor carpi radialis, palmaris longus, pronator teres, which we can't see because we're too far down. Right, okay, and we have flexor carpi ulnaris and flexor digitorum superficialis. The 3 deep muscles is the flexor digitorum profundus, right, okay, flexor pollicis longus, and if we go under now, you can barely see it. I haven't dissected it out because I don't want to destroy my things. What you're seeing down there is the pronator quadratus. That's the pronator quadratus. What you can see the muscle down there? If I were to go and show you the origin from the ulna to the insertion on the radius, that will destroy all my structures there. So nobody's going to ask about the pronator quadratus. They're going to ask you about it. Now can everybody find it, the anatomical snuff box? Well, before I go to the anatomical snuff box, I'm going to show you a muscle that comes over on the anterior aspect of the arm. Let me just do this for you. Alright, okay? There we go. Alright? If you mid-pronate your forearm like that, you have created the cubital fossa. This is the cubital fossa right here. This is the brachioradialis, and this is the pronator teres. Pronator teres has an origin from the medial epicondyle, and it strays up onto the medial supracondylar ridge, and it runs across the forearm like that, and inserted into the middle of the radius on that side. Right? This now is the brachioradialis. This comes from this is an extensor muscle. It's a posterior compartment muscle that has been pushed onto the anterior compartment. Right? So, there it is. It arises from the upper 2/3 of the lateral supracondylar ridge, right, on the humerus, right, okay? And then it runs down across the radial aspect of the forearm. So when I do that, that's what we're seeing over here. But about halfway down here, right, it becomes a flat tendon. A flat tendon. And anybody can tell me what are the two important things you're going to find under the brachioradialis, right? Brachioradialis, yes, is from the humerus, from the upper two-thirds of the lateral supracondylar line. So Michael Lamont, the mic wasn't working this morning, right? But you're going to tell me the two structures you find under the brachioradialis. We'll show them to you. You run down on the cover of the brachioradialis. All right, let's ask Shalini Ramjit. What are the two structures that I'm going to show to you? Anybody? Okay, well, I'm going to show that to you. So here, this is what happens to the brachioradialis. It comes down to this tendon, flat tendon. Right? This flat tendon is going to be inserted right here above the radial styloid. Right here. Right, that's where it's going to be inserted. Right above the radial styloid here. Right, okay? As it comes down, it has two important structures running on it. One here and one here. Right? One is going to leave it on its medial aspect, right here. Right, okay? And one is going to leave it on its lateral border. So medial is ulnar and lateral is radial. Hold on, I'm going to come again, guys. Right on this here, leave it on the lateral border. Right, everybody can see that very well. That's a radial nerve. Now, radial nerve is a complex nerve. This is the superficial branch of the radial nerve. Right, okay? This is a sensory radial nerve. There's no motor fibers in this. This don't supply anything in the forearm. It just runs through the forearm to the dorsum of the hand. Alright, okay? So this is superficial, and we can see, right? Well, I'll show you the branches in a while. Now, what is leaving under the medial aspect? Anybody can tell me what this big boy is? This is the medial aspect. This is the radial aspect. This is the ulnar aspect, the ulnar border, right here. This is medial. This is the lateral border to the radial. So under the radial border is exiting the radial nerve. Under the ulnar border is exiting the big artery here is what? Radial artery. Very good. All right, okay? Radial artery. So you're going to take each one in turn and see how it runs. All right, okay? Get into the hand. So much to tell you about, okay? Okay, well, let me just, right, okay? Dr. Shetty went over all this with you? Or you want me to go over it again? All right, I'm just going to show them to you quickly, all right, okay? All right, so this is the radial artery. Why I'm doing that? Because you're going to meet it in the hand. So I want you to make certain. You want to go over again, all right, okay? All right, okay? So this is going to go, find the anatomical snuff box. Everybody find the anatomical snuff box. All right? Right, that's the anatomical surface. Who is going to tell me what is the ulnar border of the, this is the radial border, right? Right, this is the radial border, two tendons here, and this is ulnar border because it's closer to the ulnar. Who is going to tell me what this tendon is? Who is going to tell me what is this tendon? The EPL. Very good, Jodian. Jodian, I know Jodian. Jodian did anatomy with me before, so she should answer. Okay, Jodian, very good. I know Jodian very well. Right, okay, right? Yeah, I recognize the name this morning. Right, okay, right? So, the extensor pollicis longus. What you guys have to do is this, you see? Have small WhatsApp groups, because the days of getting together, we're not going to be able to meet for another couple of months, it looks like. Form small WhatsApp groups, talk it over with each other. Call someone and say, tell me the boundaries of the anatomical stuff box. If you read it, you're going to forget it. I'm telling you, right, okay? You have to talk things over. Right, so I know it's hard, you're separated and all that, but you have each other's number. Ask someone. I'll have WhatsApp today. So just WhatsApp them and ask them these things. What's the ulnar border? The EPL. What's the ulnar border? What's the radial border now? Who can tell me? That's Jordan again. Jordan. It's the EPB and one more. Two tendons. Abductor pollicis longus. Abductor pollicis longus. Very good, Shanice. Very good. Abductor pollicis longus. So let me just show you those, right? Okay? So here, this is the EPL. This is the EPL here, right? And this is the APL, sorry, APL, and this is the EPB, right? Okay? So this extensor pollicis brevis is going to go, right? Okay, to the proximal phalanx of the thumb. EPL is going to go to the distal phalanx of the thumb, whereby the abductor pollicis longus is going to go into the metacarpal, the base of the metacarpal, and the trapezium of the tongue. Right, okay? They are going to, this is going to abduct the tongue. Right, okay? Abductor pollicis longus. So, running under these two tendons, right here, is the radial artery. The radial artery is going to leave the forearm and run through. And if you feel, right, everybody can see that? Can see that? Good. Right? If you feel in the anatomical snuff box now, right here, you're going to feel a radial pulse again. Janice, can you feel it? Put your finger in the anatomical snuff box and you feel your radial artery again. Radial pulse. Alright, good. Alright, then look what the radial pulse is going to do. Alright? After it leaves the anatomical snuff box, it's going to enter the hand here by running between the two heads of the first dorsal interosseous muscle. This is what we should be talking about, right? Instead of all these things. Anyhow, I'm leaving that for now. Oh yes, I want to show you the radial nerve. The radial nerve is going to break up into branches. Alright, these branches here, you can see them? I need it. Okay. Alright, this is the radial nerve. Right, and these branches are going to be running on the EPL tendon to go to supply the cutaneous sensation for 3.5, the dorsal 3.5 fingers. Dorsal thumb, dorsal index finger, dorsal middle finger, and half of the ring finger. Right, okay? So this is very important. If you feel on your EPL like that, right, this is your EPL. If you just lightly move your finger along your EPL, you can feel those cords. And those cords there, they feel sensitive because they are the branches of the radial nerve that are going to go into the hand. Okay, now we spoke about the 6 compartments under the extensor retinaculum. Right? Let's try and find them. Right? Everybody remembers the extensor retinaculum? Alright, so here, I hadn't told you about this, but not only at the MCP joints, I told you that we have these palmar plates or palmar ligaments. Right? Palmar plates or palmar ligaments. Right? The thickening of the anterior capsule of the metacarpophalangeal joint. Well, they're held together by this tendon here, right? Okay, called the deep transverse metacarpal ligament. So they are actually making your hand firm because these metacarpal heads can't separate. They don't go over to the thumb. The thumb isn't shown here. This is the index finger, middle finger, little finger, ring finger, and middle finger. Right? So those are the palmar plates or palmar ligaments. There's a thickening of the anterior capsule, held together by a deep transverse metacarpal ligament, and then we have the fibrous flexor tendon sheets running right down the fingers, right here, right, okay, and into those are going to go the flexor tendons of the flexor digitorum profundus and the flexor digitorum superficialis, right? On the extensor side now, this is what the extensor tendon looks like, right? It runs, right? It runs here from the distal 2/3 of the radius here, right, okay, to the pisiform and triquetral bone, right here, right, okay, right, it runs right across there. And it has 6 compartments on there. And each of those compartments you have to know the tendons, the tendons that go through. So this is what the picture would look like, right, okay? This is a picture of an actual dissection, right? This is really a thickening of the antebrachial fascia. So the antebrachial fascia in this region is thickened. And they have septi that go through to the bone and that separate these compartments. So I'm going to show you the 6 of them now, right? The first compartment, right, has these 2 tendons, right? Cut it open there for you. This one, right, has 2 tendons in it. And those 2 tendons are the EPL, right, okay? Right, not EPL, sorry. APL, right, okay, and EPB. Right, these are the tendons on the radial side of the anatomical soft box. Then we have these 2 tendons now. This is the second compartment. Second compartment has these 2 tendons. Anybody can tell me what those are? They are coming from 2 muscles that are running down behind the brachioradialis. Right? Anybody can tell me? If somebody wanted to find about the deep transverse metacarpal ligament. Okay, all right. These are the radial extensors. Radial extensors. That's not extensor digitorum. This one here, right? This one I'm going to show it to you further down. Right? Okay. Here they are. Further down. Right? This is the extensor carpi radialis brevis. And see how big the tendons are? And this one, the extensor carpi radialis longus. Right? They are the radial extensors. Just like you have radial flexors, the flexor carpi radialis. Well, here you have 2 radial extensors. So this one is the extensor carpi radialis longus. Right, okay? That comes off, that arises from the distal 1/3 of the lateral supracondylar ridge. Right? Okay? Extensor carpi radialis longus and brevis. And Cellini, very good. Now the second compartment. The third compartment now, I have to move some things here to show you. Right? I have to do them in separate places because here is the EPL. EPL now is going to be in a compartment. This is the 3rd compartment, right here. EPL has its own compartment. Now that is the EPL, that's extensor pollicis longus. If we look at the back here, so it's not shown as well here as in here. It's kind of moth-eaten. This is called the dorsal tubercle of Lister. Dorsal tubercle of Lister. Right, okay? Dorsal tubercle of Lister. Right, okay? Right? This is the left side and this is the right side. It's a different way. Okay? The dorsal tubercle of Lister will be right here. The extensor carpi radialis longus, the extensor pollicis longus tendon winds around it to give it a mechanical advantage. And then it runs in its own compartment there, right here. Right, okay? Own compartment to go right to the distal phalanx, right, okay, of the thumb. And we can see it here, extensor, right? Pollicis longus, coming right down here in its own compartment. The white right here, you can feel the dorsal tubular pelvis down here. You can actually feel it. My finger is right in it right here. It winds around it to give it a mechanical advantage, then it crosses, in turn, it crosses the extensor carpi radialis brevis, extensor carpi radialis longus, and then it runs right up to the distal phalanx of the thumb. And that's the big extensor. That's for the thumb. The thumb has two extensors. Extensor pollicis brevis and extensor pollicis longus. Right? And it's the extensor pollicis longus tendon that you can feel these radial nerves on. You see the radial nerves here, they're going all the way up to supply, right, okay, medial 3.5 fingers dorsal. Then, everybody wants to see this, everybody has wanted to see this now, right? This is the big muscle here, this is the extensor digitorum, right? So this is extensor digitorum, yeah, that one is extensor digitorum minimi. This is extensor digitorum. It has 4 tendons, right? Extensor, let me come. There we go. Can I go down a little bit on it? Okay. That's 4 tendons. It runs its own compartment, right? And those 4 tendons are going to be inserted into something called extensor expansion on the fingers, which I'm going to show you in a little while. The extensor expansion, right? Okay. But there's another thing, another muscle that runs in that tunnel with it. Anybody can tell me? A bit earlier, if you can find it again. Here we go. Here we go. There it is. Small muscle there. That's the extensor indicis. Nobody's going to ask you to about that. They're not going to ask you to identify that at all. So that has a tendon now, which is running down in the same compartment with the extensor digitorum, right? And they are going to be inserted. Use another hand here now, right? Okay, onto the dot, right? They are going to go into extensor expansion, which I'm going to show you in a little while, right? I'm going to show you the flexor retinaculum, and now I'm showing you the extensor retinaculum. I'm going to go back to the flexor retinaculum, right? Okay. One more compartment now, right? Is taking this tendon. Anybody can tell me this one? It arises in continuity, almost at one mass with the extensor digitorum. It's a separate muscle. Who can tell me this one? Going to the little finger. Chanel? Extensor digitorum minimi. Very good, Chanel. Very good. Excellent. Excellent. And then this one everybody knows is the extensor carpi ulnaris. Extensor carpi ulnaris. Right? So I want to show you something. This is flexor carpi ulnaris. And this is extensor carpi ulnaris. You see how they're on the same side? Sorry, come again. Okay, alright, okay. So this is one here. Right? So you see how they're on either side of the they both have a aponeurotic origin from the subcutaneous part of the ulna, and they're on the ulnar side of the arm. So when they contract together, look what they do. They ulnar deviate the wrist. The two of them will together ulnar deviate the wrist. Just like the flexor carpi radialis and these two radial extensors, right? These are the wrist extensors. So when they contract together, they will radially deviate the wrist. They will radially deviate the wrist. Right, okay? Alright? Alright. So let's go back now to the flexor retinaculum. Alright? It has 10 things in it. Let's see if we can find them. I'm going to find them in this one because this one has been dissected so many times. Should be able to find them easily. we have down in here are the flexors for the fingers, right? Okay. If we pull these, right? Okay. All right. These anteriorly here, these are the flexor digitorum superficialis. And if we go posteriorly, right back here, is the flexor. Back here, these are the flexor digitorum profundus. Right? So you can see they all flex the fingers. They flex different parts of the fingers, right? Okay? After coming through the flexor retinaculum, this is the superficialis, okay? And the one underneath here, this is the superficialis, okay? And this one is the profundus. Right? This one is the profundus. Right? So they run across the hand, the palm of the hand like that. When they get to the MCP joint, as they enter the fibrous flexor tendon sheath. And guys, this is the fibrous flexor tendon sheath here. But you can see that? This is the fibrous flexor tendon sheath. Right? And it has a synovial part. You can actually see a vincula longer coming there. Right? But it has inside of it is a synovial, a flexor synovial sheath. A flexor synovial sheath lining a thicker fibrous flexor tendon sheath. So the fibrous flexor tendon sheath lined by a synovial sheath. As we get to the proximal phalanx, the flexor digitorum superficialis is going to split into two. 1, 2. Right? Okay? And what's going to pass through it? The flexor digitorum profundus. Flexor digitorum superficialis is going to be attached on either side of the middle phalanx. Right? Okay? On either side of the middle phalanx. More towards the palmar side, not the dorsal side. Whereby this flexor digitorum profundus is going to go right through to be inserted into the base of the terminal phalanx, right here. Sorry, let me just put it right here. Base of the terminal phalanx, right here. Right? So, suppose somebody comes to me now with they've had a laceration across the hand here. Right, okay, and I want to know which one of those tendons are cut. Right? If I were to keep this, what happens is that the flexor digitorum superficialis flexes the proximal IP joint. And the flexor digitorum profundus is going to flex the terminal, the distal IP joint. So this is the metacarpophalangeal joint. This is the proximal interphalangeal joint, and this is the distal interphalangeal joint. So if I were to keep this joint straight, and I can flex that distal IP joint, then it means that my profundus is intact. Now, if I were to restrain these two fingers and ask the person to bend the PIP joint, keeping the DIP joint straight, right, okay, and they can't do that, then it means that is the flexor digitorum superficialis, right, okay, which is cut, right, okay, because one flexes the superficialis, flexes the PIP joint, and the profundus flexes the DIP joint. Anybody have any questions at this point? It's a test you're going to be doing over and over, right? I've done surgery for many years, and I want to tell you something. This area here, cuts there, very, very common. People slash their wrist. I have one chap who put in a pane of glass, and he put it in the pane of glass and cut it right across. When you look down in there, all you're seeing is these things. They look like spaghetti. So we call it the spaghetti wrist. Right, okay? This is just a surgical, colloquial sort of term. Spaghetti wrist, I mean they have cut tendons. They try to decide which is which. Because a cut flexor tendon is a completely different thing from a cut extensor tendon. These flexor tendons on this side, the muscles, flexor muscles are bigger, they're stronger, and the proximal part is going to retract way up. So if you cut your flexor tendon down here, the proximal part quite often retracts upwards. Right, okay? Whereby that's not the case in the extensor and the extensor side. I'll show you. Right? So we're going to look at the 10 things that are in the carpal tunnel. So this one, big boy, which I'm going to talk about tomorrow evening, is the median nerve. Right, okay? What it comes to the median nerve, all these branches here, common palmar, digital, proper palmar, digital, all these branches. Then we're going to see 8 tendons, right, okay? 4 of the flexor digitorum profundus, which are behind it, the superficialis, right, okay? 4 of the profundus, okay? And then we also have one that's going this way. Let's see, this one is it. Pull it and see. That's I can tell right away that's for the index. Go here now, this one here. Look at the flexor thumb. Alright, want to see that? So that's flexor pollicis longus. Flexor the thumb. Right here, flexor the thumb. So you have 4 superficialis, 4 profundus, flexor pollicis longus, and the 10th structure is the median nerve. When pressure is brought on that median nerve sometimes, like people who have women who do a lot of housework, right? Ariel, I don't think Ariel will ever do housework. She's going to be a doctor, right? Ariel, you love spaghetti, Ariel. Okay, all right. Okay, but Ariel, are you planning to do a lot of housework? I don't think so. You're going to have a big job as a anesthetist or emergency room physician. I have a daughter who's an emergency room physician in New Zealand. Okay, she doesn't do any work. Her husband is a chef, and he does all the housework too. So the women don't do any work. Okay, right? Okay, the doctors they tend not to do housework. But people who do a lot of housework, washing and ironing and cleaning floors and all those things, they can get overuse those tendons sometimes, and they get swelling to the tendons, and it presses on the median nerve, and they get carpal tunnel syndrome. Or they may have osteoarthritis of the carpal bone, so they may have rheumatoid arthritis and bring pressure on the median nerve. They get pain going in the hand. So many times I've had to cut this flexor retinaculum just to relax the median nerve. Now, the carpal tunnel and which is the flexor retinaculum, so not carpal tunnel, the flexor retinaculum and the extensor retinaculum, they're what we call pulley systems. They direct the action of the muscles. Right, okay? That's why once you have a pulley, right, then you're going to need to lubricate the pulley. So inside of those flexor sheets now, we have synovial membrane. Right, okay? So now we have flexor synovial membrane, extensor synovial membrane around the tendons. Huh? All right. What I'm doing today is just showing you some things. Right, we have a lot of things to cover. Anybody have any questions at this stage before I go on? So before I go there, right? So I've shown you the extensor retinaculum. I've shown you the flexor retinaculum. I want to show you one more structure before we get into the intrinsic muscles, right? And that is the extensor hood or the extensor expansor. All right? If I show you here, these are the flexor tendons. Here we have 2 of them. All right? Okay. This one is most likely coming from the extensor digitorum, and that's from the extensor indicis under there. Right? Okay. Right. The middle finger only gets 1, and that is from the extensor digitorum. Right. The little finger gets 2. It gets one here, right? Okay, and it gets one from the from the extensor digitorum also, right? Okay, but they also have intertendinous adhesions between them, intertendinous connections. So even here, they have intertendinous connections. So when these get cut, they don't retract as much, right? So these are easy to repair, right? Okay, because they have intertendinous connections. Show me that. Okay, so each extensor tendon is not going to be inserted directly into the bone like the flexor tendon. It goes into a fibrous expansion, which I've dissected out here for you, right? Okay, right. So everybody can see that, right? Okay. Try the light again to see. The light reflects off of it. So. Okay. That's not a good idea. Right, okay? Alright, so this is the extensor expansion. Alright? And that extensor expansion has a base, right, which comes back here, and this base here, right, is going to be inserted, right, okay? The side of the base is going to be inserted into our good friend, the deep transverse metacarpal ligament, right? And into the sides of it also is going to be inserted the interossei and the lumbricals. If we look at this picture here, you can see this is the base, this is the tendon going here, right? The extensor tendon. The base is going to go back. The sides of the base of the triangle is going to go back and be inserted into the deep transverse metacarpal ligament. But the sides also, inserted into the sides are the lumbricals, which I'm going to show you, and the interossei. Lumbricals and the interossei. Right? Now, this expansion then splits into three bands. Right, okay? A central slip, a middle slip, right, which is inserted, right, okay, into the second. By the way, this happens at the MCP joint, so the proximal phalanx here. This is going to be inserted into the base of the middle phalanx, the central slip. The collateral slips now, these two, they're going to run alongside the middle phalanx there. They're going to come together and they're going to be inserted into the base here of the distal phalanx. Okay? And the purpose of this expansion is that you can actually flex, right? Okay? It allows the small muscles of the hand, the interossei and the lumbricals, to flex the MCP joint and extend the IP joints. Right? Okay? So now I think we can move on to the muscles. Before I do that, I want to show you a structure. And I'm sorry, I don't have more of it preserved. This is all I have preserved. Alright? And somebody identified it earlier as the palmar aponeurosis. Right? Palmar aponeurosis. It's a very important structure. Right? Because I know that none of these, right? Once you start dissecting a hand and you're going to dissect the deep structures, you literally have to sacrifice the palmar aponeurosis because it covers everything here. It's just a piece of it. Right? Okay? The palmaris longus is inserted into it. The longitudinal fibers of the palmaris become the longitudinal fibers of the palmar aponeurosis. So I have a picture to show you. So it's in the section here, right, of the palm and the hand. This is the thenar eminence. This is the hypothenar eminence. Right, so the base of the thumb here, the base of the little finger. Those two things I showed you earlier. Well, this palmar aponeurosis, right, it has longitudinal fibers which are continuous with the palmar fundus. And as it gets to the distal transverse skin crease, right about here, those central strands, those four strands, start dividing into slips. And for each finger, those slips are going to literally dive into the hand, right, and get themselves inserted into, right, our good friend here, right? The three things that are right here together. So one slip come down here is going to be divided into two strands, right, okay? Or one band divided into two slips there. One slip is going to go on the ulnar side and one on the radial side of each metacarpophalangeal joint, and gets itself inserted into three things: the palmar plate, the deep transverse metacarpal ligament, and the fibrous flexor tendon sheath. See how the hand is held together, right? It works. It's a very mobile organ, held together so you can lift the weight. There's no strain on anything, right? Because of all these connections, okay? So on the extensor side a while ago, we saw the bases of these extensor expansions going back to be inserted onto these. Right, okay, right here, to the deep transverse metacarpal ligament. And now we have the bands from this, right, okay, that are going down now, and they're going to be inserted, right, deep now into the deep transverse metacarpal ligament, the palmar plate, and the fibrous flexor tendon sheath. Right? This is going to provide a cover for the superficial palmar arch, right? All the superficial nerves. Right under this, if you get a cut in your hand here, blood starts spurting, because under there you have an arterial arch which is provided, we'll show you tomorrow, it's mainly from the ulnar artery, and a deep palmar arch which is based on the radial artery. Alright, so this is the palmar aponeurosis. Now, I'm going to come back now, and we're going to start with the short muscles. Okay, I'm a fellow of the Royal College of Surgeons, and they give me a free subscription to something called Ackland Anatomy. So if you look at the thing with Ackland is that I like the pictures in Ackland. You can get good images on Ackland Anatomy, right? But I find the anatomy discussion, some of them leave a little bit to be desired, right? Okay, so I wouldn't go there to learn my anatomy. But if you want to see good pictures, they're there. Also, University of Michigan has something called Blue Link, right? Okay, and University of Michigan, I actually know the person there, and we email each other because I thank them because they made the dissection pictures public to all the universities around the world. So it's called Drexel University. Just Google University of Michigan Anatomy, and you can get images, or Ackland Anatomy. All right? And now, especially now you're not in the anatomy lab, you need. You can see my passion for anatomy. All my students tell me that. I get carried away sometimes with anatomy. I spent almost 40 years, or 30 years doing surgery. And I got to the top, senior consultant surgeon. And then as I got older, I figured that I've always loved anatomy. I used to demonstrate in anatomy when I was a surgical resident. So I've always had a love for it. Right? Okay? Anyhow, let's get on with it. So what I want to do now, we're going to come to the muscles. So let's see if we can talk about the 19 muscles. But we're not going to get to them because Shanique is beginning to shake her head at me. Right? So let us see. First of all, I'm going to show you the dorsal interossei. Right? The 4 dorsal interossei. Right? You won't see the palmar interossei. I'll show you the adductor pollicis, and I'll show you all the thenar and hypothenar muscles. So I can't show it to you on this one because I didn't want to disturb the back of this forearm, so I wouldn't show you the interossei on this, okay? Because for me to show you the interossei, I have to move all these things. Right? If I've done here, this one, right? So you can see that, right? So look at 5 red pins then, 4 red pins. That's the first dorsal interosseous. Alright, okay? If I can just pin this one away with a different color pin so you know where it's here. Those are the extensor tendons I've taken there, okay? This is the second dorsal interosseous, and I can't dissect them out any better than that. If I try to dissect them out better, they're very adherent to the fascia and all that, okay? Then the third dorsal interosseous, and this is the more red. Right? 4th dorsal interosseous. So first, second, third, and fourth. Their line they arise, okay? The first dorsal interosseous, right, okay? They're bicipital. I showed them to you in the lecture this morning. It has 2 heads, right, okay? One head arising from this side more dorsally, and the other one right here, right? Second one is here, the third one is here, and the fourth is here, right, okay? So that's what you see in there. First, second, third, and fourth, right? Now, I should have been in a picture now. Here we are, right, okay? 1, 2, 3, 4. 4 dorsal interossei. Right? They arise from both sides, so we call it bicipital. They have 2 heads. Right? And they have a short tendon, which is going to split into 2, called bifid, a bifid tendon. Now, dorsal interossei abduct. I told you that in the lecture this morning. Right? Dab. Right? So, dorsal interossei, that's more than 1, okay? The abduct, A-B-D-U-C-T, right? And the mnemonic for that is DAB. Then I'm going to show you the palmar. Well, I'm not going to show them to you in the specimen. I wouldn't have any specimen left. The palmar interossei, the adduct, and that is pad. And that you'll be hearing that all the time, right? Okay? So when if you look at the middle plane for the finger, when we're adducting and abducting our fingers like this, right? Right? We have a point, which is the median, and that's through the middle finger. Right? Now, when you get to the thenar muscles and the hypothenar muscles, you will see that the little finger has its own abductor, right, okay, called the abductor digiti minimi, and in the thenar eminence, that's it, the hypothenar eminence, in the thenar eminence, there is a abductor for this, two abductors for the thumb really, right, okay? So that doesn't need to be abducted. So the four digits that need to be abducted, three digits that need to be abducted really, right, because this has its own and this has its own, is the middle finger, which needs to be able to go in either direction. Right? So the middle finger needs to be able to go that way and that way. Right? So when we abduct, right, when the middle finger goes that way, right, that's the same as radial deviation. When it goes that way, that's the same as ulnar deviation. We just call it abducted, right? Okay? So these two have their own abductors. So the middle finger needs to be abducted in either direction. So that takes two interossei. One of the bifid tendon, or a part of the bifid tendon, goes into the base of the proximal, proximal phalanx, right here, right? Okay, and then the other part is going to go into the extensor expansion or the extensor hood, right? Okay, right. So those are the dorsal interossei, right? Now, first one, this one here, right? Okay, this is the most powerful. The first dorsal interosseous, right? Okay, is what we call one of the two key pinch muscles, right? Okay, so I have a key here. So when I want to squeeze a key to turn into a lock, then I need to be able to abduct this finger and I need to adduct my thumb. Those are the two key pinch muscles. So I'm going to show you the adductor pollicis in a little while, right? And those are very important action every day. Starting a motor car, opening your door at home, right? Okay, those are two very important. See these small muscles, what they do? The long flexors and extensors, they work on the fingers. But these small muscles, they are the intrinsic muscles. They rise in the hand and they get inserted in the hand. So they are there for the mind, for the small things that you do. Right, okay? Writing, caressing somebody you love, okay? Playing a piano. I like to see a very good pianist play, right? You know, these are the small muscles that do it, the interossei and the lumbricals, right? The adductor pollicis, right, okay? And these thenar and hypothenar muscles. They are the fine actions that you do. When those go wrong, right, you'll find there are 19 of them. And 14 of them are innervated by the ulnar nerve, only 5 by the median nerve. On the ulnar nerve, something goes wrong with the ulnar nerve, right, okay? Then you get a claw hand. You can't use your hand again, right, okay? Because all those muscles just stop working and they get fibrotic, right? And your hand becomes useless, right, okay? So you have to know that, right, okay? Now, we move on now to the parma interossei. You'll never see them. There's no dissection I've seen around here that shows them. Alright, okay? Because by the time you get down to them, you either have to remove the dorsal interossei, right, to get to them, and you can't see them very well, so you have to see them from the parma side. So those now are on the parma aspects, right? On the sides of the metacarpals, but parma, not dorsal. The medicine we call is volar, V-O-L-A-R, volar parma. So that's what they are, right here, right? But we only need 3 of them. And this is the reason why. Right? Right? What are they going to do? What did I say they're going to do? Who will remember? Shanice? What does the parma interossei do? Adduct. Very good. Adduct. So the thumb has a big adductor, which I'm going to show you. It has its own adductor. Right, okay? So all that really needs, the middle finger doesn't need any adduction because that's in the median plane. Understand that? That doesn't need any adductor at all. All that needs to be adducted, right, is the index finger, right, the ring finger, and the little finger. right? Okay, those are the only three that need adductor. So those are the only three, right, okay, that has a palmar adductor, a palmar interosseous. And again, the same thing. They have short tendon. The difference between this and the dorsal are more powerful. The dorsal have bicipital heads on both sides, right? Like this, right? Heads coming from both sides of the metacarpal. Remember, this only have the head on the metacarpal that's going to be adducted, right? Okay. So this one got to adduct the little finger. This is going to adduct the ring finger. This is index finger, right? So those are the palmar interosseous. Then we come now. I have a muscle here, which I'm going to show you. Hope you can see it. I don't want to damage my stuff, you see. This muscle here, this is the big, right? Everybody can see it there? That's the adductor pollicis. The adductor pollicis, right? That's a big muscle, right? Okay? It has two heads. It has a transverse head and an oblique head. A transverse head and an oblique head. A transverse head and an oblique head. Right? That's, I can show it to you on this one too. This is my better hand, so I really want to disturb it too much. But if we look in here, all that we see in there, all of this is the adductor. Right here is the adductor pollicis. Alright, so let's see where that comes from. I don't have a picture of that. Oh yes, I have a picture to show you. Yeah. Alright. That comes from the transverse head comes from the entire length of the third metacarpal. And the oblique head comes from the bases of the second and third metacarpal and the capitate bone, right here. And the two heads come together and they're going to go towards, this is the thumb here, right? The thumb has two sesamoid bones. They're not shown here, right? The flexor pollicis longus tendon is going to run right along here to be inserted up there. But they have two sesamoid bones. A sesamoid bone is a bone in a tendon, and the tendon is then inserted into a bone. This seems to help the muscle to act better. Right, okay? So we have two sesamoids for the thumb, and the patella, for example, when you get to the lower limb, is a sesamoid bone. Dean at 4 o'clock, okay, alright. 5 minutes, alright, I'm going to, there's nothing, one thing I don't want to do is to keep the Dean waiting, okay, alright. Right, the Tom and Paul is doing an excellent job in this crisis, and I have the utmost respect for him. I would never want to keep him waiting, alright, okay. But what I'm going to do tomorrow, I'm going to finish up, alright, I'm going to give you a few minutes now to put yourself together. Tomorrow, we're going to finish up the muscles of the hands. So I want you to read up about the adductor pollicis, and then I want you to read up about the three muscles that are in the tena eminence. That's the abductor pollicis brevis, the flexor pollicis brevis, and under it all here is the opponens pollicis. And then the abductor digiti minimi, the flexor digiti minimi, and under it is the opponens digiti minimi. Alright, and then we would have completed them. Oh no, and the lumbricals, 4 lumbricals also. We haven't done the lumbricals as yet. Alright, okay, so the lumbricals, we're going to do the lumbricals after we finish the adductor pollicis, and then we do the tena and hypotena eminence, and then we start with the innervation and the blood supply. Alright? And listen to me. If you go into my Socrative quiz, right, you will find most of this stuff. And if you have any problems, drop me an email on my university email, and that's dadfrancis@uemona.edu.com, and I'll be happy to answer it for you. Alright? If you have any questions, tomorrow afternoon at 2 o'clock. Alright? Have a good day, guys. Alright? And keep safe now. Okay? You're welcome. I'm glad everybody enjoyed it. Thank you.